Hello everyone, my name is Kathleen Yoder, and today I'm presenting to you on Gene Watson's theory of human caring. These are some learning objectives for our presentation and my thesis statement that Gene Watson's theory of human caring is a theory of nursing practice that transcends both grand and mid-range theory with the focus on acute illness, prevention, promotion, and restoration of health, while incorporating spirituality, holding consistent to the vision of nursing being an evolving practice. So Jean Watson was originally from West Virginia. She graduated from the Lewis Gale School of Nursing as a diploma nurse. She proceeded to work for a few years where she met her husband. They married and moved to his home state of Colorado. While there, she got her BSN from the University of Colorado. She proceeded to get her master's and her PhD in educational psychology and counseling, all from the University of Colorado. She developed her theory on human caring between 1975 and 1979 from her own personal views of nursing. Her work was influenced by her teaching, her education, as a way of finding a common meaning among nurses. In the 1990s, she had some more evolution of her theory of human caring and eventually founded and directed the Watson Caring Science Institute. In addition to these things, she is a distinguished scholar and has been the dean of the nursing school at the University of Colorado Health Sciences Center. She is also a past president of the National League for Nurses, and she is widely published in multiple languages. So Watson herself has been able to describe that her theory can be read either as a grand theory with a conceptual framework that sort of gives us a broad overview for general practice, or it can be read at a structural level, interpreting it and interventions, which can be tested empirically. So the middle range theories tend to come and evolve from the grand theory. The theory is mostly about the relationship between the nurse and the patient. It makes the patient front and center for the nurse, not the illness. The nurse sees the patient holistically, and she is most known for the 10 curative factors, which encompass the bulk of the theory. Over time, it has evolved to be renamed the 10 curative processes. She has taken the phrase curative and derived it more from the play on the medical side of curative and their role of curing an illness, where Watson views nursing as curative and they're there to care for the patient holistically. So here we have the theoretical framework for the theory of human caring. We see that the patient and family are centered in this framework. They are on top of a globe, signifying the importance of the environment. And then they are sort of encompassed and surrounded, like that of a hug, by the 10 caritas. We can see that the nursing values and goals for the patient are what is holding up this framework. So this theory and how it pertains to the nursing meta paradigm. So in terms of nursing, she believed that there needed to be a reciprocal relationship between the nurse and the patient. Nursing needed to prepare themselves to care for the patient as much as needing their sort of empirical educational background as well. So it was important for the nurses to look into themselves and put away their biases and their differences in order to fully care for the patient. In terms of the person or human being, she looked at them as having three dimensions: the mind, body, and soul. And her focus was, as stated earlier, holistically and to treat the mind, body, and soul all as one. In terms of health, she felt that the individualized health perceptions must be considered. So each patient is, again, not to be looked at as an illness, but as a patient, and each patient requires specific interventions tailored just to them. Lastly, we have the environment, and Watson believed that you needed to have a healing and curative environment made by the nurse through those 10 curative factors, sort of as we've seen on that framework in the slide earlier, where those 10 curitas were encompassing the patient and their family. So here we have the 7 assumptions to the theory of human caring. She feels like these 7 assumptions are necessary for appropriate caring for a patient. The practice of caring, number 7, being central to nursing, is important to look at because she frequently will transcribe caring and nursing interchangeably, meaning that when she talks of nursing work, she's really talking about caring for the patient. Some of the other assumptions involve how interpersonal the relationship requires between the nurse and the patient, and that by effectively caring for the patient, we can have health promotion and growth and prevention. So next we have our propositions and concepts. The first one being transpersonal caring relationship. And this is the nurse's commitment to protecting and enhancing the human dignity. The nurse is caring and having connections with this patient in order to have a healing experience. The nurse's roles go beyond just sort of objective assessments, and they are showing care for the patients in relation to their own health. This really shows the mutuality between the patient and the nurse and the importance of their relationship. The caring occasion and caring moments is that moment in time when both the nurse and the patient come together on a human-to-human level. It's the moment where the nurse's caring is influenced by her own background, and the patient's perceptions is influenced by their own background. And then they take both of this history and they bring it together to meet in the middle. And then next we have those 10 curative factors. So on this slide we see the original 10 curative factors and then the evolution of the 10 curitas processes. And you can see by moving from a factor to a process where the idea of the grand theory and how that can be read into a philosophy has changed to a middle range theory, and you're starting to see specific interventions that can be tested and quantified. So if we take something like number 9 and the assistance of gratification of human needs, and we bring it over to the 10 curitas processes, where it specifically states that it's assisting with the basic needs as a sacred act. We will see on the next slide a little bit more about those basic needs. So Watson took on number 9 and actually performed an outline of this hierarchy of needs, with the lower needs orders being the need for food and fluid, the need for elimination, ventilation, the need for activity, inactivity, and the need for sexuality. So most of those needs you can see are basic human needs that are all biophysical needs. Her higher order of needs, which is the more important needs that she felt that pertained to caring and what the patients required, was the need for achievement, the need for affiliation, and then the highest order being the need for self-actualization. And you can see here as that none of the higher order needs pertain to any of the physical needs of the patient. So one of the journal articles that I found was in the 2017 Peer Journal, The Concept of Watson's Curative Factors in Nursing and Their Dis or Harmony with Patient Satisfaction. This journal article I found really interesting because it just shows the broad scope that Gene Watson's theory of human caring has, that it's able to transcend multiple cultures and languages all the way out till Sylvania, where this study was conducted. And what we saw here was looking at relation of levels of nursing education, nurses as compared to nursing assistants and throughout the hospital, and to see if it affected patient satisfactions based on Gene Watson's theory of human caring. And what they found was that there wasn't really a significant differences between the curative factors and the education, but mostly it was in the perceptions of the patients, and that when nurses were acting and caring in the way that patients believed they were supposed to, patient satisfaction levels went up. And oftentimes nurses are seen as these caring figures, and so patients are expecting to have their nurses sit and talk with them and have a broad knowledge base and find the importance of their own background to be of importance, and then to utilize all that information to give appropriate care and formalize an individual plan for the patient. So the next article that I have here is out of the Permanente Journal from 2015, which was more of a retrospective look at how this institution, the Kaiser Permanente of North California Patient Care Services, had gone on this journey to embrace the sort of core tenets of this caring science, and then to incorporate it into their practice and environment and really make it the culture of their organization. And so this article was meant to sort of provide context on the background of how a professional practice framework could be used to transform that culture across multiple hospitals within a integrated delivery system. And then in addition to that, it provided evidence and showed us how they were able to integrate this caring science across all different areas of the health institution, the administrative, the operational, clinical areas, and how it contributed to increased patient satisfaction, which leads to better health outcomes. So some of the strengths, weaknesses, and my own application of this into my nursing practice. The strengths are that it's easy to understand. There's not a lot of technical terms. It's very logical to put the patient in the center of their care, along with their family and environment. And it doesn't take any abstract thinking really to realize that when you can look at a patient as a whole and not just an illness, you can provide better care for a patient. It definitely enhances the nurse-patient relationship, and it really gives personal nursing care to each of the patients. And I see this a lot in my area of nursing. I currently am working as a labor and delivery nurse, and I have the luxury of most of my patients' ratios being 1-to-1 or 1-to-2 patients. And during a 12-hour shift, you can give a lot of specific time to those patients. While you're laboring somebody and they're contracting, and you have physical hands-on the patient, and you're learning about their history, and you're learning about the environment that they live in, you can tailor the way that you're caring for them. In addition to that caring, we're sharing our knowledge that we have in educating the patient on each of the next steps of their labor processes. So some of the weaknesses of this theory is, as we saw in the hierarchy of needs, they put any of the biophysical needs very low importance on the patients and the science of caring. It's very much so open to interpretation, and there's no definitive direction on how to actually achieve this authentic caring. This we can see in our nursing practice, as I said, of the labor and delivery nurse. I am at the bedside providing one-on-one care with my patients. We have a lot of interpersonal time, and the education and the knowledge sharing between the patient and myself is of importance. But if that patient's here because they are having some hypertensive issues associated with their pregnancy, you can't negate the fact that those medications and that physiological issue is still of importance. So here we have a 25-year-old female who prevents in latent labor with no prenatal care. Upon admission, we do a standard urine tox screen for anybody that doesn't have prenatal care, and we find alcohol and methamphetamines. So we're starting to use the nursing process through the theory of human caring, the same as it's intended to be used as the scientific process. We are building that transpersonal relationship with the patient and using our caring moments and caring occasions to sit down and learn from the patient about their background, about their environment. And during this assessment, we're just gathering all kinds of information so that we can see the patient holistically in order to formulate our plan that will be individualized for the patient. And when we implement the plan is specific to this patient and this history and her background and her family and her environment. And then, of course, evaluation at the end. We're going to go through our assumptions, those 7 assumptions that Watson talks about. And then we're going to start using our caritas to really follow through with our caring and seeing the patient holistically. So in order to start using these caritas, the nurse really needs to be aware and knowledgeable about what the patient needs, and they need to have intention to act on asking these questions in order to make positive changes due to this caring. And they need to be genuine and they need to be sincere. So in order to follow through with our caritas, we're going to start with the first one in this scenario, and that is to practice a loving kindness and equanimity. And in order to do that, we need to put aside the fact that this female has been using alcohol and drugs throughout her life without thinking about her unborn baby and how the effects of her choices have on that fetus. We need to be authentically present for the patient, instilling hope and faith. And we do that by encouraging the patient through her labor process. And we do that by learning about her fears and her excitement and what we can do to help alleviate some of those concerns. And then we're going to continue on, and we're going to use cultivations of one's own spiritual practice and transpersonal self. So we're going to kind of go beyond ourselves, and we're going to open up with compassion and sensitivity for the situation that this female is in. Next, we're going to continue to develop a trusting relationship. We are going to have authentic caring for the patient. We're going to counsel her that there is a possibility that she may not be able to go home with her baby and the reasons why. And through that, we're also going to be promoting and accepting the expressions of all of their feelings, positive and negative. She needs to be able to grieve for the possible loss of her baby, as well as the excitement of having a child. We are there as her nurse in order to provide that comfort and that sounding wall and the knowledge that we have of the situation and what we can do to help stabilize her feelings. We need to be able to problem solve and openly look at a way to move forward with this patient so that she sees that the opportunity for a healthy baby to be cared for when she is in an unhealthy state is really the best option for the patient. Next is the promotion of interpersonal teaching and learning, and from there we're going to educate the patient on the possibility of the baby being in the NICU and signs and symptoms of withdrawal that this baby might have and medications that we would give the baby in order to help alleviate those withdrawal symptoms. We need to be supportive to her environment. If she's not comfortable talking about her substance abuse background in front of the large medical population, then we need to know to just take one of the residents or the attending physician in the room with us and have that smaller, quaint conversations about her history. We're going to also care for her basic human needs. We are going to meet the criteria for labor. We're going to be able to empty her bladder as needed when she's epiduralized. In addition to that, we're going to give her a cool cloth to help soothe her forehead during these trialing times. And then lastly, we need to help her show that there is an opening and attending to spiritual and mysteriousness, that all of this is happening for a reason that is greater than us and greater than our beings. So as we can see in the case study, that the theory of human caring is just so simple and logical. It's very practical, and that we're able to encompass all areas of this theory in a simple 12-hour shift that we can have with our laboring mom. Thank you all for listening. I hope you enjoyed the presentation and you were able to meet your learning objectives.